Larry. I have Dr. Jamie Phillips with us and Sue Prohaska, and we are going to talk about the intersection of COVID and flu season. And Larry, I need you to enable sharing on my screen, and I will pull up the presentation. Fantastic, thank you. So why is this important, especially for employers in terms of the intersection and flu season? Again, I'm Jen Roberts with Fair Whole Health, and we wanted to provide meaningful insight to individuals and the employer community on the intersection of COVID-19 and flu season. And we've put together a great panel. We have Roche with us, and they are the leaders in creating the devices that are actually testing for flu and COVID. And they are the parent company of Genentech, and they actually create and distribute flu vaccine, as well as representation from a great employer, Rice University. So why is this important? And y'all have probably heard this hashtag, because 2020. So thinking about this as an issue, you've been seeing probably some recent press coverage on concerns about flu season with COVID. And I pulled a recent quote from Dr. Fauci, and he says, we're looking to have a drop in COVID-19 daily cases by at least 30,000 a day in the US to avoid a quote disastrous flu season. That was in early September. We're running around 40,000 cases a day, and according to the CDC's website, their most recent stats are from the 23rd of September, and we're at 41,310. So we weren't able to make that stretch goal of dropping COVID by 75% in September. And this is important because flu stretches the hospital systems in just a normal flu season, and utilizing the resources. So according to the 2018-19 flu season, over 56 million Americans had the flu. That translated into 26 million doctor visits and 740,000 hospitalizations. So if you think of that for a second right there, and what we're already dealing with COVID, what kind of impact that can have. So there's duplicative symptoms. There will be a disruption in the workforce. It's going to impact the health of your population. And we're also going to be concerned about dual infections, people having COVID and flu. So the impact to flu is interesting, and Dr. Phillips is going to talk about this a little bit. But because of masks and social distancing, and because we're going to have some extra testing, we might have a higher case rate, but a little bit less severity. And thinking about workplace preparedness, if ever a time for an employer to really put the hard press on getting flu shots, getting testing done, and different measures for safety and preparedness, this would be the right season. So with that, I wanted to turn it over to Dr. Jamie Phillips to give us some insight on state of the industry.
Thanks, Jen. So today I'm going to be talking about the different tests that are available for SARS coronavirus 2 as well as influenza, and what we should be asking ourselves when we start to say which tests should be utilized. So all of the evidence that's presented in data in this presentation is based on our current understanding. So just like the virus evolves, our understanding of the disease that it causes, COVID-19, is also evolving. Next slide, please. So the picture of the virus on the left has become ubiquitous. I think within the past year, it's safe to say that most people can accurately identify it as a coronavirus due to its protruding spikes, right? So coronaviruses get their name. They've got an outer glycoprotein, which is known as a spike protein. And when viewed under an electron microscope, it gives it this crown-like appearance. So I've actually had the opportunity to study coronaviruses and other respiratory pathogens for over the past decade. My PhD, as Jen mentioned, focused on infectious diseases, specifically coronaviruses, and looking at the genes that these viruses have that make them cause a more severe disease in different hosts, or actually cause less disease and become attenuated, which is what we see with vaccine strains. So coronaviruses, just like this image, are ubiquitous. They infect many species, and as alluded in our first talk today, this pandemic was inevitable, right? So we know that there's been 2 other notable zoonotic transmission events, which is the occurrence of a coronavirus or any virus being transmitted from animals to humans. So the first one was in China in 2002 with SARS coronavirus 1 and MERS in 2011. Next slide, please. So current day, I'm at Roche Diagnostics, and I'm supporting their medical and scientific affairs group for respiratory testing at the point of care. And then since last January, I've been serving on their emergency response team. And our goal is to bring reliable tests to market. And we know that approximately 70% of all clinical decisions are based on these diagnostic test results. If you could go ahead and advance the slide, Jen. But we know that diagnostic tests are just one piece of the puzzle, right? So they enable clinicians to appropriately cohort patients so they can isolate and those individuals to prevent the spread. But ultimately, we still need an effective treatment as well as an effective vaccine. For the purposes of today's talk, I'm going to be going through specifically looking at the different diagnostic tests that are available. Next slide. And so there's really 2 questions we can ask ourselves. One is a person currently infected with the pathogen SARS coronavirus 2? Or the second question is, has a person been exposed to the virus? The first question is going to be looking for the pathogen, and there's different tests that you can use to identify this. One of them is a nucleic acid amplification test, which is actually amplifying the genetic material. Another is an antigen test, which is identifying a protein on the virus. The second question, when you're asking, has a person been infected, what that test is recognizing is actually a protein that our bodies are making in response to the infection. And so these are called immunoglobulins. And so we can look back at historical coronavirus infections, and we know for SARS coronavirus 1 that typically these immunoglobulins in individuals who have seroconverted, meaning they were infected and then they developed the antibodies, those antibodies live about 2 to 3 years. We're still understanding for this specific novel virus how long antibodies are present in individuals and if these antibodies are actually neutralizing. And what neutralizing means is that it would actually confer protection. So it would reduce the risk of reinfection, which is really important to understand as we start to get back to normal. Next slide, please. And so I just want to ground this all in the stages of viral infection before we talk about when these tests should be used. So as mentioned, this virus is usually transmitted with the respiratory droplets. It infects our host cell and takes over the machinery, replicates up to a certain point, and in a normal individual, that person will mount an immune response, and those antibodies that then neutralize the virus are able to be created. And so that typically takes about 7 to 14 days for those immunoglobulins to be created. Next slide. And so and if you could go ahead, perfect, thanks, Jen. The clinical stages of COVID-19 can be broken down into 3 stages. So let's just break this diagram down. On the y-axis, you're looking at the severity of illness. And then on the x, you're just looking at the course of time during the infection. And so stage 1, which is typically what most individuals who are symptomatic experience, is going to be your early infection. So your symptoms are fever, dry cough, diarrhea, headache. Your stage 2 is when you start to see the hypoxia, the shortness of breath. And then as severity increases, which this occurs in less individuals, you lead into stage 3, which is your hyperinflammation phase. This can lead to acute respiratory distress syndrome, cardiac failure. And I did want to point out additional tools, diagnostic tools that can be used by healthcare providers to manage stage 3. And one that we'll talk about briefly today is IL-6. Next slide. And so going back to those two fundamental questions of, are we looking for the pathogen to identify a person who's potentially infectious, or are we looking to see, does this person potentially have a reduced risk to reinfection? We would say for the first question, a nucleic acid amplification test could be used. And typically the specimen types that are collected for these are your nasal, nasopharyngeal, orphangeal, etc. Whereas for the antibody detection, you're going to be using serum or plasma for that specimen type. Next slide, please. And so it's important to understand not only which test should be utilized when you're trying to answer these questions, but the time frame in which they should be used within individuals. So here on the y-axis, we have the concentration of what we're measuring from the different tests. So the dotted line is indicative of nucleic acid and antigen. So this is the virus itself that we're measuring. Whereas the solid lines, the light blue and the dark blue, are again your proteins, your immunoglobulins. And so you can see here that roughly 4.5 days post-onset of clinical symptoms is when you have the highest viral load. And so some of the tests that are on the market that are antigen tests actually have within their package insert that should a person present post 5 days onset of clinical symptoms, those negative results should be reflexed to an additional test, a nucleic acid amplification test, to ensure that you do not miss that individual's infection. Additionally, when we see it takes about, as mentioned, 7 to 14 days for our body to mount that immune response. And so if you think that you've been exposed and you display clinical symptoms and you're wanting to know, do I have those antibodies? You need to wait so that your body has time to develop them so that they can then be detected by the test. Next slide, please. And so we talked a lot about sensitivity with antigen and nucleic acid amplification, saying, looking at the days post-onset of clinical symptoms. But when we start to talk about the antibody test, if you could go ahead and click through, Jen, really what's important here is specificity. So there are other human coronaviruses that have been circulating annually. They account for about 10 to 15% of the common cold every year. But these tests, we want them to have a high specificity so that when you get a positive immunoglobulin result, you know that that result is saying, yes, you were previously infected with SARS coronavirus 2 and not just another coronavirus. Next slide, please. And so there's still a lot that we're learning about the immunoglobulin assays. They are essential for epidemiological studies, surveillance, and vaccine studies. If you could click through. But as mentioned, we are still building our understanding around the risk of reinfection. Next slide. And so because we're talking about the interface of SARS coronavirus 2 and influenza A and B, which are co-circulating and have an overlap in clinical symptoms, I wanted to talk about viral co-infection. Next slide. So last year's flu season started October 2019 and went through this past March. The CDC's estimated that there's about 39 to 56 million cases that then resulted in 18 to 26 million medical visits. So each flu season is different. And that's essentially what this picture to the left is depicting, because you can see the different colored lines are representing different flu seasons. Next slide, please. So there's a nice study that looked at about 1,100 individuals. Of those 1,100 individuals, 116 of those were positive for SARS coronavirus 2. They then looked at those individuals that were positive for SARS coronavirus 2 and said, how many of those individuals are also infected with another respiratory pathogen? And so you can see the list of pathogens on the left here. And basically what I want to highlight is the highest percentage of co-infections occurred with SARS coronavirus 2 and rhinovirus or enterovirus at roughly 7%. Following that, we saw a co-infection rate of about 5% for respiratory syncytial virus. And then for influenza A, we saw a co-infection rate of 0.9%. And for influenza B, we saw 0 co-infections. Granted, this was data from last year's flu season, and every flu season is different. But this is indicating that co-infections for flu and SARS are going to be rare. But it's still essential for healthcare providers to be able to differentiate these two when they're diagnosing. So the use of a multiplex assay that's testing for these pathogens at the same time is important, because then it's utilizing all of the reagents that we have more appropriately. We know that, the swabs and the UTMs that are needed to run these tests are at an all-time premium. Next slide, please. And so briefly, I just want to talk about that additional test, managing critically ill patients. So in addition to testing for, next slide, please, the pathogen itself or the host immune response, for critically ill individuals, so we know about 20% of individuals are hospitalized, and they have a median length of stay of 10.1 days in the hospital. Next slide, please. Interleukin-6 is a cytokine that our bodies produce as part of hyperinflammation. It has received EUA, and so healthcare providers can now utilize this diagnostic test to aid with their prediction of respiratory failure, which is just providing objective data to assist in mechanical ventilation resource allocation. Next slide, please. And so, we know that our work is not done. There needs to be broad access to reliable SARS coronavirus 2 and influenza tests in order to essentially identify those that have been infected and to contain the disease, as well as the need for antivirals and vaccines. So next slide. As I mentioned, I've been serving on Roche's emergency response team, and it has been an incredible opportunity to be able to use my knowledge to work alongside all my colleagues to develop these tests. And as mentioned, we are working around the clock to continue to bring more tests to market so that all of your needs are met.
Thank you, Dr. Phillips. Appreciate that. And our next session, we want to talk a little bit about how employers can prepare. And I did want to thank Dr. Phillips. She's the medical and scientific lead for affairs at Roche, and she's an expert on respiratory pathogens. So the background is really helpful, especially with flu and COVID coming together, and what things have looked like in the past with flu.
Jen, that next slide.
Gotcha. So thinking about flu season and how employers can prepare. So typically people come to work, they may have cough or sniffles during flu season. Maybe they miss a day or two and then they're back. Well, what are your other employees or your customers going to think if their coworker, the person helping them, is coughing or sniffling, et cetera? So that's why it's so important that we really work together to tamp down this flu season as much as possible, thinking about protocols for safety at work and social distancing. What are the options for vaccines, maybe mobile clinics and curbside testing and vaccines? And if you as an employer can't put something on site or in place for your employees and spouses or dependents, what are the community options that you can market and share in different modalities, email, flyers, mail homes, different things like that that's current and relevant, and sharing information with your organization about what you are doing to prepare. And then again, back to what Dr. Phillips was saying about the right test at the right time. So if you are putting these services available for your employees, and especially related to kind of return to work, making sure that they're getting the right test at the right time. And we have Sue Prohaska. She's the benefits director at Rice University. She worked formerly as a consultant at Mercer, and she has her law degree. She's also the chairwoman of the Houston Business Coalition on Health. So we wanted to bring her on for an employer perspective. They're really doing a best in class that we could learn from. And I wanted to just real quick show a picture of their webpage. So this is their landing page. And you can see Rice University has a pretty large population, around 3,000 or so employees, a large student population, many of which live on campus. So they kind of have to run like a little town there. And as you can see, for any students, employees, visitors, contractors, first thing up there, red line, latest updates on coronavirus and current situation. So I just wanted to pass it along to Sue.
All right, thanks, Jen. Next slide. All right. We have all the work that we've done for managing the coronavirus has been, based on science, experts from the CDC, our own experts, the Texas Medical Center, which is literally right across the street. So we are doing a science-based return to work. We do have quite a few contractors on the location, but they are required to have their own policies and procedures to manage the health of their employees, with the expectation, of course, that they will contain disease. So we have been testing and testing and testing and testing. We run about 1,000 tests a day for students and employees. So in August, we conducted a little over 9,000 employee tests with 15 positive outcomes. So we have had very good success in managing the disease burden. We had the first week of September, we had no positive cases. We did have 3 positive cases last week. So we have done a very good job at containing. Students, faculty, and staff, everybody who is on campus is required to get testing. We also have robust contact tracing. We were able to redeploy some employees who couldn't work from home, and they were trained to do contact tracing. And then they've found it meaningful and productive, and have appreciated the opportunity to be able to help their fellow employees. The contact tracing has definitely resulted in quarantine and isolation of students and employees. And what we have found is that people aren't getting coronavirus here on campus. They're getting it when they participate in gatherings that are away from campus. So next slide, Jen. So we started with return to work because we had to get people back to work before we could have students back to school. So we had several phases. We started off with most everybody working from home. Then we moved into phase 1 where we needed to get folks back in the research labs, largely graduate students and faculty. And then we needed to bring back those who were necessary in order to get the students back to school. We had every single employee do an individualized return to work plan, every employee, every department, and we did that so that we didn't have there weren't questions about how we were going to do things. It was clear to everyone how we were going to return to campus. We have made accommodations for those with health conditions and caregivers. We in the Houston area are largely still taking care of students at home. They are not in school for the public schools to a large extent. So we have made accommodations for those who have children at home. And we have several groups that are going to exclusively work from home for the fall semester. Entire floor of our building are completely empty. And so, but those of us who need to be here are. And we're also staggering shifts. They've done this really well in the housing and dining area to make sure that if one person gets sick, they don't have to quarantine the entire housing and dining staff. We've got administrative controls, cleaning, signage. We're requiring appointments for all meetings. We're we're limiting meetings. Conference room, every conference room in the whole university has a new capacity sign on it. So we're limiting that. And then we have engineering controls as well, such as the plexiglass in the public areas, furniture placement. We've got cleaning materials everywhere, PPE. We got an electronic assistant here in our department so that we don't have to open the door to everyone. There's hand sanitizer everywhere. So we're really going all out with the engineering controls. And then as far as staffing safety, everyone who is on campus is required to wear a mask. Our police department is stopping people. And insisting that even visitors wear the masks. We have daily health assessments. We are recommending flu shots to our employees. We are not requiring them. We are including a drive-up option and also encouraging community resources. And then we have return to work documentation requirements for when they are ready to come back to work if they've been out. Next slide. The return to school has been an interesting process. There has been a tremendous amount of communication from the Dean of Students. The students got a pre-arrival health behaviors and supply list for the fall semester, including thermometers. They have a culture of care agreement, and every student was required to sign this, saying that they agreed to be good stewards of their fellow students' health by following the rules, wearing their masks, checking their health, getting their testing done, all of that. We had town halls, we had regular messaging. There's an email that went out every single week to give people updates on what was going on with the return to school. All students who were on campus, they were tested before arriving on campus, before they were able to go to their dormitories. Every student came through and had a test done, which went very, very, very smoothly. We are requiring flu vaccines for the students as well. And then when we think about the physical environment, we do have a separate dorm for those who test positive so that they are isolated. Dining is takeaway meals only. We've got tents all over campus so that people can properly distance and be together at the same time. And our classes are being conducted in a hybrid model. They're always being recorded, which is especially important for those international students who are not able to get back to campus.
Thank you so much, Sue. That's such an interesting example of kind of running your own small community. And I think probably a lot of employers that are participating today may have large campuses as well, where you really can control that environment and make a significant impact, not only on your particular campus, but for the community as a whole. So I think, Larry, we might have a couple of minutes for Q&A. If you've got any questions that come through or people would like to ask for Sue or Dr. Phillips.
No, we don't have any questions that have shown up, and actually we are out of time. So I do want to thank everyone for participating. Thanks Jen and Sue and the doctor for being part of this activity. If you have any questions, please send those to us. We will be trying to respond to those after the session. At this point, please log out. We are going to have a 15-minute exhibit and networking break. I want to encourage you all to visit the exhibit hall. We are giving away prizes. It'll be at 1:30 Eastern time. We will announce those winners. So please take the time to visit, get yourself some coffee, walk, and meet some other people in the meeting. And we'll see you back here at half after the hour, which would be 12:30 Eastern time. Thank you all very much. Thanks again, Jamie, Jen, and Sue. Bye-bye.
Thank you.